Welcome to this masterclass. We're chairing ourselves today, and I'd like to introduce Michael O'Reilly from Birmingham, and he's going to talk about the role of androgen excess in disease pathogenesis and metabolic dysfunction in women with polycystic ovary syndrome.
Okay. So, thank you very much for the introduction and to the Society for the invitation to speak to you. I'm obviously very honoured to be speaking alongside someone of the calibre of Professor Franks, who's dedicated his career to improving our understanding of PCOS. So my talk is going to be quite androgen-centric, as the title might suggest, and hopefully over the next 15 minutes or so I'll take you through why I think androgen excess is a central driver of metabolic complications in PCOS. So, polycystic ovary syndrome is highly prevalent, affects about 10% of women of traditionally of reproductive age, but probably of all females. We now know this to be a lifelong metabolic disorder with complications from the in utero period right through to the postmenopausal phase of life. The health complications include a significantly increased risk of hyperglycemia, lipid disorders, and increasing evidence recently of cardiovascular disease and non-alcoholic fatty liver disease. We know that androgen excess and insulin resistance are the two main drivers behind the adverse metabolic phenotype in PCOS, but it's not very well understood what the primary derangement is, and the reality is that PCOS probably represents the common clinical endpoint of a heterogeneous series of disorders. So I'm not going to speak too much about diagnostic criteria today. It's perhaps something that Steve will speak about later. So androgen excess has sort of typically been considered a bystander or an association in the context of PCOS-related complications, but there's emerging evidence now in recent years that they're actually directly complicit in metabolic dysfunction. This very elegant study from Jill Goldstein's group in Harvard in JCM this year caught my eye, and essentially what they did was they took serum samples from women in the 1960s, and then they followed their offspring longitudinally and prospectively. And then these androgens were sampled at the beginning of the third trimester of pregnancy. And what was really interesting was that those female offspring of mothers who had androgens in the upper quartile had a fourfold increased risk of metabolic syndrome. And there were increased risk factors for hypertension and for glycemia. And actually these associations were not observed in the male offspring. Our own work in collaboration with androgen in Chicago has shown that even by the age of 3 years, daughters of women who have PCOS actually have increased urinary markers of systemic 5-alpha reductase activity compared to controls. So this is the important androgen activating enzyme that converts testosterone to dihydrotestosterone. So we're seeing evidence of complications related to androgen burden in children, in daughters of women who had PCOS, but also early disturbances in the daughters themselves in terms of androgen metabolism. So how mechanistically might we link androgen excess with insulin resistance in PCOS? And part of the explanation may lie in adipose tissue. So the adipocyte is an important organ of androgen generation, and it expresses a complex network of androgen activating and inactivating enzymes. One of these is AKR1C3, which is aldoketoreductase type 1C3. It converts androstenedione into more potent testosterone. Its expression is closely correlated with BMI, and it actually reduces after weight loss. So some of our work in Birmingham in recent years, we wanted to tease out what the adipose tissue androgen metabolome was, particularly in the context of PCOS. And then we wanted to find out if these locally generated androgens were actually capable of modulating adipose tissue function. So when we think about lipid metabolism or lipid flux, this essentially refers to a delicate balance between lipid accumulation on the right and lipid breakdown on the left. So accumulation occurs as a consequence of reesterification of free fatty acids with glycerol, glucose uptake, or actually de novo lipid synthesis within the adipocyte, and that's regulated by genes like ACC1, or acetyl-CoA carboxylase type 1. And then breakdown on the left, the predominant processes are beta oxidation, whereby free fatty acids are broken down into, or are converted into ATP in the mitochondria, or lipolysis, which releases free fatty acids and glycerol. And it's not really very well understood how androgens might impact on that process. So there are fairly consistent non-human primate data and other animal studies showing that female adipose tissue is adversely impacted by pre- and postnatal androgen exposure. But we felt that there was a distinct lack of data on human studies. So with this in mind, we designed a dedicated clinical study and a complementary in vitro arm. We recruited 10 PCOS women and 10 BMI-matched non-PCOS controls. We gave them 100 milligrams of the androgen precursor DHEA, and then we sampled their serum every 30 minutes for serum androgen generation, and we did adipose tissue microdialysis, so collected fluid every 30 minutes in tandem with the serum test. If anyone's not familiar with adipose tissue microdialysis, so this is where we insert a microdialysis catheter under local anesthetic into the subcutaneous adipose tissue. We perfuse fluid across a semi-permeable membrane, and we collect fluids in small vials at the other end. And this can be sampled for androgen quantification. You can measure real-time markers of insulin sensitivity, etc. And then we took some fat biopsies as well. So what we found using sensitive mass spec-based techniques was that the adipose androgens, testosterone and dihydrotestosterone, were significantly increased in the PCOS women compared to controls. And we were surprised to see that the intra-adipose concentrations of these androgens actually far exceeded the circulating levels. We weren't even able to quantify 5-alpha dihydrotestosterone in the serum. And then we found increased mRNA expression in the PCOS women in their subcutaneous fat. This is our androgen activating enzyme. Expression was enhanced compared to controls, and 5-alpha reductase type 1 expression was actually suppressed. And this data has been shown in older cohorts as well. So then in vivo, we went on to measure glycerol in the subcutaneous fat depots. Glycerol is an indirect marker of lipolysis, so disturbances in glycerol content in a cell can give us some information about lipid flux. So after we gave DHEA, you can see that the adipose glycerol levels in both groups, but particularly in the PCOS women, they're the black continuous line, were suppressed. And the comparison between the two groups in terms of area under the curve is generated in the graph on the right. And then using primary cultures of female subcutaneous adipocytes, we went on and performed de novo lipogenesis. We used stable isotope techniques, so the uptake of carbon-14 acetate into the adipocyte is a direct marker of new lipid synthesis within the cell. And you can see that in response to potent androgens, this process was upregulated. And that was further supported by an increase in our prolipogenic gene ACC1. So taken together, these data support a role for androgens in lipid accumulation or adipocyte hypertrophy. So we feel that there is a vicious circle at play in PCOS adipose tissue. So enhanced androgen generation within the fat depot, driven by AKR1C3, leads to lipid hypertrophy. This can lead to insulin resistance, metabolic dysfunction, and then the high insulin levels associated with this in data that I've not shown you can be seen to drive AKR1C3 expression and activity. So I want to take you back to our dreaded steroid biosynthesis pathway. and AKR1C3 is actually a very important gatekeeping enzyme in several androgen biosynthesis pathways. So most of us will be familiar with the classic pathway, and that's where adrenal precursors like DHEA, androstenedione, are activated in the periphery and in the ovaries into more potent androgens like testosterone. But some of us may be less familiar with the 11-oxygenated pathway, and this has been around or known about for many years, but very much understudied. What we do know is that adrenal CYP11B1 is capable of converting androstenedione to 11-hydroxyandrostenedione. This undergoes conversion to 11-ketoandrostenedione, and this is a very good substrate for AKR1C3. So the conversion of 11-ketoandrostenedione to 11-ketotestosterone is actually a much more efficient reaction than its counterpart in the classic pathway. And data from our collaborators in South Africa has shown that 11-ketotestosterone and 11-ketodihydrotestosterone bind the androgen receptor with equal affinity to their classic counterparts. So with this in mind, we wanted to determine what their role was in polycystic ovary syndrome. So in collaboration with Karel Storbeck, who's based in Stellenbosch University in South Africa, we analysed serum 11-oxygenated androgens and their precursors in serum from 115 women with PCOS and age and BMI matched controls. And we were able to show that levels of these metabolites were significantly increased in PCOS. And furthermore, if you note the concentrations of 11-ketotestosterone in PCOS women, they're actually double the concentration of the classic testosterone that's measured in serum. And actually, when we measured the respective contributions of the classic and 11-oxygenated pathways in these cohorts, you can see that the 11-oxygenated pathway actually contributes to the majority of the circulating androgen burden in this disorder, much more so than in the healthy controls. So mechanistic studies and small-scale observational studies are nice, but what are the real-world metabolic complications for women with PCOS? So non-alcoholic fatty liver disease is essentially the hepatic manifestation of metabolic syndrome, and it represents a spectrum of liver injury from simple steatosis or lipid accumulation right through to fibrosis and cirrhosis. There's some small-scale evidence in the literature, including a 2017 meta-analysis that suggested that the risk of NAFLD was about 2.5-fold higher in women with PCOS than in controls, but this has not been looked at systematically. So we wanted to tease this out further, and some of the postulated mechanisms behind this were increased insulin resistance, where you get free fatty acid trafficking into the liver, or maybe a direct effect of androgens themselves on the hepatocyte. So we wanted to examine this in a large population sense, and we managed to do so in collaboration with colleagues in the School of Applied Health Research in Birmingham. So they used the THIN database, or the Health Improvement Network, and this is a primary care database in the UK. It covers about 700 GP practices, about 3.5 million patients, so about 6% of the population of the UK. And what we did was we followed 63,000 women with PCOS, accepting the limitations of these kind of data, and compared them to 120,000 aged and matched controls. And what we found was that the risk of NAFLD in PCOS was about 2-fold increased, similar to what that meta-analysis showed. But interestingly, this group here with a BMI of less than 25 are already at an increased risk compared to controls with a BMI of less than 25. And this is a group that we would have kind of traditionally ignored in terms of a negligible metabolic risk. And then to try and tease out an independent effect of androgens on this process, we split serum testosterone concentrations in about 15,000 patients into septiles, so according to their measured concentration. And you can see that once the serum testosterone level goes above 3 nanomoles per liter, that's when this risk of NAFLD becomes clinically manifest. So what about glucose metabolism? Well, there's population data that suggests that the risk of diabetes in PCOS is about 3 to 4-fold higher than in the background population. A Scandinavian study some years ago suggested that women with PCOS on average develop diabetes about 4 years before non-PCOS women. And we showed about 4 or 5 years ago that in women who had elevation both of androstenedione and of testosterone, that they had a 25% chance of having an abnormal OGTT. And that was significantly higher than women who had elevation of a solitary androgen or of no androgens, with normal androgen metabolism. So we went back to the THIN database and essentially we followed 70,000 women longitudinally but retrospectively for 5 years, and in keeping with other published data, we found that there was an almost linear relationship between serum testosterone concentration and risk of diabetes. But what was very interesting was that risk actually became significant when a woman's serum testosterone concentration was 1.5 nanomoles per liter or higher. So typically actually considered within the normal physiological reference range. So I will just wrap up with the final number of slides to diverge slightly and just talk about some scenarios where we need to consider diagnoses other than PCOS. So we need to think potentially about congenital adrenal hyperplasia. The vast majority of these are due to 21-hydroxylase, about 95%, 21-hydroxylase deficiency. Most of them will present in the neonatal period. But simple virilizing forms can present at any time in the reproductive cycle, and very often we see patients with menstrual dysfunction and hirsutism presenting with an elevated 17-OHP. We need to think about adrenocortical carcinoma. So if there's severe elevation of adrenal androgen precursors or other warning signs such as rapid onset hirsutism, overt virilizations, or signs of hypercortisolism, then we should expedite abdominal imaging in that scenario. In the postmenopausal woman, particularly if there's isolated elevation of testosterone, think about ovarian hyperthecosis. Usually imaging will show bulky ovaries bilaterally. The diagnosis can usually be confirmed biochemically with GnRH suppression testing. So testosterone elevation in these situations is gonadotropin dependent. It should switch off significantly in response to GnRH analogs within about 28 days. Usually the treatment is bilateral oophorectomy, but if it's a premenopausal patient in that rare situation, you may need to think about localization studies. And then other rare causes include Cushing's disease and ovarian tumors. So we wanted to look at the androgen excess signature of a large cohort of women presenting to our service since 2012. So over 5 years, we examined 1,200 women biochemically who were referred with suspected androgen excess. And of these, 400 had elevation of at least one of either testosterone, androstenedione, or DHEAS. So we went on to kind of clinically phenotype this cohort. And what we were able to show was when we stratified serum DHEAS levels, or the patients with serum DHEAS levels, into quartiles according to the elevation of their serum androgens. In the premenopausal women, the vast majority of these still had PCOS. So there was a solitary ACC in this cohort. So it's still about a 90% chance, even with severe elevations of DHEAS. It's a bit less clear-cut with serum testosterone. But with the postmenopausal cohort, you'll see here that every single one of these female patients with severe DHEAS elevation turned out to have an ACC. So menopausal status and age is a very important discriminator of the risk of non-PCOS neoplastic disease. So I will wrap things up there. Take-home messages from my standpoint are that Our androgen excess is a cardinal central feature of PCOS, has significant health consequences, and future therapeutic interventions must focus on reducing androgen burden. Androgens are produced by adipose tissue through AKR1C3, and this is where they start to exert adverse effects on lipid biology within the adipocyte. 11 oxygenated androgens, hitherto ignored for many years, constitute the majority of circulating androgens in this disorder, and there's a role in years to come for routine clinical laboratories to measure these androgens. And then lastly, always consider non-PCOS pathology in a woman referred with androgen excess, particularly postmenopausal cohort or the very severe biochemical disturbances. I'll finish by thanking a few people without whom this body of work would not have been possible. My mentors, particularly Wiebke Arlt in Birmingham, who's a real innovator in this area and who's been instrumental in my career. My colleagues in the lab, the mass spectrometry people, my excellent clinical colleagues, and the basic scientists who have helped me understand science a little bit better. So, thank you very much.
Thank you, Michael. That's lovely work. We've a bit short of time, but time for a couple of quick questions. Yes, can you go to the microphone, please? While they're getting to the microphone, I could ask you quickly, so can you regulate these key enzymes, and if so, how? Because obviously that gives you some therapeutic options.
Yeah, so thus far there's been some experimental work with AKR1C3 inhibitors, predominantly in vitro in the context of hormone-resistant prostate cancer. There is now some pharma activity around AKR1C3. It's of interest in endometriosis and increasingly in PCOS. So selective inhibition of this is certainly a promising therapeutic target going forward.
Good.
Hello.
Hi.
Barbara McGowan, London. Thank you for that really interesting talk. Two questions. We know that weight loss does improve metabolic syndrome. Have you measured 11 androgens, after weight loss? Do they improve? Do they get better? And my second question is, often I tell my ladies with PCOS to have laser treatment rather than being poisoned with lots of anti-androgenic treatment. Is that the wrong thing to do? Because obviously with laser treatment, I'm not actually decreasing their androgenic load, which obviously is linked to the pathogenesis of PCOS. So should I be doing both? Is there any evidence that?
I mean, there are no controlled studies to say that lowering androgen burden is of metabolic benefit. But all the data now at this point is heading in that direction. And what we need now is a clinical trial. I think in primary care, ideally, unless there are complications, an anti-androgenic oral contraceptive pill should be, very high on the treatment list. Treating patients symptomatically for hirsutism, that's also an important part because, these patients have significant comorbidity in terms of mental health, quality of life. That's been shown definitively by Aled Reese's group in Cardiff recently and in other studies. So you do have to treat symptomatically, but I think biochemically going forward and metabolically, reducing androgen burden is one of the few things that's likely to reduce their metabolic risk. Going back to your first question, so AKR1C3 expression reduces with weight loss. We haven't looked at 11 oxygenated androgens per se after weight loss, but all our clinical intuition would tell us that they're likely to be lower. So absolutely, weight loss is a very important therapeutic intervention.
Thank you.
Thank you, Michael. Okay, so it's my turn. I'm going to cover management of polycystic ovary syndrome in about 15 minutes. So, if I could have the first slide. Here we go. So I'm not going to remind you about what polycystic ovary syndrome is, but I am going to come back to this issue that we heard in Dr. Lean's talk about the importance of obesity. And the importance of obesity comes into effect also when we're talking about the effects on polycystic ovary syndrome. So, for example, you see here that women who are overweight or obese are more likely to have menstrual disturbances and more likely to have hirsutism. And as we'll see later, because I'll concentrate mainly on the long-term consequences of polycystic ovary syndrome and how to manage them, this is really a very important factor. So what needs to be managed? Well, it's quite a long list. I've categorized it by presentation, really. So oligo or amenorrhea, so there you're talking about regulation of menses or induction of ovulation. Hirsutism, persistent acne, alopecia, the signs of androgen excess, obesity, and we've heard about the importance of non-alcoholic fatty liver disease, quality of life issues, and long-term health concerns, which, as I say, will make up the most of my talk. Diabetes, cardiovascular risk. Does that mean cardiovascular events? Not necessarily. And very briefly, endometrial cancer. So I think what helps us a lot in management these days is the recent publication of an international evidence-based guideline for assessment and management of polycystic ovary syndrome. And I'll try and remember to put that slide up again so that you can get the website. It's summarized in recent publications, in simultaneous publications in clinical endocrinology, and also fertility and sterility in human reproduction. And it's really the baby of Helena Teed and her team, enormous international effort, and I think a very successful one. So let's go through this briefly. Regulation of menses, well, we're talking about using an oral contraceptive, or in those women for whom it's not indicated or not desired, progestogens can help. Induction of ovulation, you've noticed I put calorie restriction first, and you'll see why shortly. Anti-estrogens and aromatase inhibitors, first-line medical treatment, and if that doesn't work, low-dose FSH. Hirsutism, acne, and alopecia, now this is a huge subject in itself, but partly in answer to the last question, it's really a combination of things, and it should be tailored to the individual patient. So hair removal methods are really first and foremost, and that may involve laser treatment, it may involve good old-fashioned electrolysis, it may involve shaving, but these are all important issues to cover. The combined oral contraceptive, of course, will suppress testosterone levels, and you may need to add an anti-androgen, cyproton acetate, for example, or nowadays, most people seem to use spironolactone. It has a slightly better side effect profile, but it's equally effective. What about obesity? Calorie restriction, well, very briefly, no one type of hypocaloric diet has been shown to be better than another. It's sensible eating, basically. Weight loss medication, well, fairly restricted. Orlistat is the only licensed one. That's not very nice to take. Future of GLP-1 agonists may well have a place in due course. And we've heard about weight loss this morning from Dr. Lean. That's really a very important approach. And I've put bariatric surgery there, but in Imperial there is a multidisciplinary team, so people who are referred to the bariatric unit aren't shunted straight into bariatric surgery, and often intensive dietary management is the preferred option. Quality of life issues, well, this is really important and of emerging importance. And you've heard from Dr. O'Reilly that hirsutism, for example, is a particularly potent cause of distress amongst women with polycystic ovary syndrome. So it's important to ask the right questions at the consultation. Women may need counseling or even psychotherapy. Medication may help, of course, in terms of antidepressants and adequate treatment of the underlying disorder. Long-term health consequences. Well, we're particularly worried about the increased risk of type 2 diabetes. The risk factors for cardiovascular disease are there, but as you'll see in a moment, we don't really have enough evidence at the moment that this will translate into cardiovascular events. And there's little doubt that endometrial cancer is more common amongst women with polycystic ovary syndrome. Let me give you an illustrative case. This is a lady who presented at the age of 32 with oligomenorrhea, hoping to conceive. She already had one child, so it's secondary subfertility. Some delay before she conceived, but nevertheless she ovulated and conceived without any medication. She since then had one further pregnancy which ended in a miscarriage, but no further children. She had irregular cycles or oligomenorrhea and mild hirsutism really from the age of the menarche. Overweight since adolescence, but what had happened is that she'd put on a lot more weight since her last pregnancy. Notably, she had a family history of type 2 diabetes, her father. So previous investigations have shown what you might expect: polycystic ovaries and ultrasound, a raised testosterone, raised LH with a normal FSH, and she'd been managed between times with oral contraceptive for cycle regulation and to help her hirsutism. When we saw her, her weight was 87 kilos, giving her a BMI of 36, and she had moderate hirsutism. But her main concern, of course, was trying to get pregnant. So what investigation should we do? How should we manage her? We repeated, of course, her endocrine tests. Again, raised LH, raised testosterone, normal thyroid function tests. Should we do more tests? Yes, because of her metabolic risk. And so she had an oral glucose tolerance test, which was normal, but the 2-hour glucose was verging towards the upper limit of normal. Fasting lipids and lipoproteins, slightly low HDL cholesterol. So the management concerns for her relate to fertility and to metabolic health, and both of these, of course, are affected by obesity. Now, fortunately, a moderate degree of weight loss, and we're talking about 5 to 10% of weight loss. So here's a logarithmic scale, and you see in this group of women, the mean body weight went from 93 to 85 kilograms, so still very overweight, but you see fasting insulin levels fell nicely, as did the post-glucose levels, and as a result of that, of the fall in insulin levels, the free testosterone level also changed. More importantly, from the point of view of management of these patients, there was an improvement in ovulation rate and fertility, and that's been replicated over several studies. Most of them, I have to say, fairly small scale, but there's general agreement that a fairly modest degree of weight reduction can improve ovulatory function. If that doesn't work, you may need to use either anti-estrogens or aromatase inhibitors. Where are we on that? Well, the international guidelines suggest letrozole has particular advantages over clomiphene, higher live birth rate, but there are really only 2 large randomized controlled trials against clomiphene, and in the LaGros study, there was a higher live birth rate. In the Armer study, a higher ovulation rate, but no significant difference in live birth rate. It makes sense to consider letrozole's first-line treatment. It does seem to have fewer side effects, but it's not absolutely solid yet, so don't be afraid to use clomiphene. Will metformin help? Well, we can dismiss that in terms of a fertility drug. It might. Cycles might be a bit more regular, and ovulation more frequent. That's been established. So if you're not in a hurry to conceive, that's quite a useful medication. And if anti-estrogens or aromatase inhibitors don't work, you may have to consider low-dose FSH, and obviously as an endocrinologist, I put laparoscopic ovarian diathermy in very faint letters, and IVF as well. So occasionally needed, but not too much in our practice. So let's go back to our case. She lost 6 kilograms on a calorie-restricted diet. She was scheduled for clomiphene induction of ovulation, but fortunately, she conceived after spontaneous ovulation, had a normal pregnancy and a full-term normal delivery. So that was a good illustration of how weight reduction, not very much, can make a very big difference to your ovulatory function. But how should you be followed up? This is a crucial issue. So what are the long-term health concerns about women with polycystic ovary syndrome? A question about whether they're increased risk of gestational diabetes, now more and more evidence that there's an increased risk of type 2 diabetes, and cardiovascular disease risk factors are there, as well as those for endometrial cancer. So the metabolic dysfunction that underpins the metabolic risk in women with polycystic ovary syndrome is insulin resistance, together with lipid abnormalities. And here's one very brief illustration of that. That's a study from Stephen Robinson and colleagues, which shows that in weight-matched patients and controls, both lean and obese, there's a reduction in insulin sensitivity, and of course a compensatory hyperinsulinemia. So what about PCOS and diabetes? Well, this is a very nice study from Australia, from the National Health Insurance Database, looking at over 9,000 women, with 6% of whom had polycystic ovary syndrome. And what you see is the prevalence of gestational diabetes was much higher in women with PCOS than in the reference population. Gestational diabetes. Type 2 diabetes, again, very much higher with the adjusted odds ratios there. So in that particular series, both lean and obese women were at increased risk of type 2 diabetes. But I think what the next slide shows, and this is from another population study, this is the North Finland birth cohort, that's 279 women with polycystic ovary syndrome, 1,600 reference, and this is from the 1966 birth cohort. Here you see a slightly different picture, because if we concentrate on these bottom two bars here, these are women at the age of 31 versus obese controls. So these are obese women, but obese women with PCO had a threefold higher chance of getting type 2 diabetes. But interestingly, if you were lean, in this particular Northern European cohort, there wasn't an increased risk. And this really emphasizes the interaction between obesity and polycystic ovary syndrome, which we see in many contexts related to long-term health. So who is at risk? Who's at particular risk of type 2 diabetes? Well, what are the implications of the diagnostic subgroups that we recognize now? What are the long-term implications in terms of screening and whether we should look at family members? So this is a slide from Moghetti and colleagues, and that really points out that reduced insulin sensitivity seems to be a particular feature of those with the classic, if you like, NIH definition. In other words, a combination of symptoms or signs of androgen excess together with anovulation. So that's the classic NIH definition, whereas those who were ovulatory but had no hirsutism, or who had no androgen excess but were anovulatory, fall somewhere by the middle and not really very different from healthy women. So it's that particular combination of symptoms that alert us to the risk of, or increased risk of diabetes. What can we do to manage women? Now, I think we could take advantage of the fact that polycystic ovary syndrome is a disorder that presents in adolescence. So if we can intervene early, that would be very good. But clearly, if you're already obese, then diet and lifestyle changes may be necessary, and those at high risk may, of course, need additional treatment in the form of medication. So how should Mrs. CL be followed up? Well, this is sort of common sense, but using really recommendations from the current guidelines, monitoring weight, blood pressure, glucose, and it's debatable still whether it should be fasting blood sugar with hemoglobin A1C or an oral glucose tolerance test. It may be population dependent for picking up impaired glucose tolerance. And lipid profile, it's suggested every 6 to 12 months, but it really depends on the individual patient and, of course, what the results show. Cardiovascular disease, this is more problematic in terms of knowing what the outcome is. So the question really posed in the guideline was, are women with polycystic ovary syndrome at increased risk of cardiovascular disease? And in women with PCOS, how do we assess the risk and try and prevent it happening? Just very briefly, just to show you that, again, the North Finland birth cohort showing that in women who are either lean or obese, in the dark blue bars, with those with PCOS, you see that they have a slight but significant increase in blood pressure, not terribly important at a single patient level, but at a population level, really quite a significant difference. So that's one risk factor. So the risk factors are present, and not just hypertension, but obesity, dyslipidemia, endothelial dysfunction. But what we lack are well-defined cohorts and longitudinal studies into the postmenopausal years when you would expect heart disease to manifest itself more in women. So what are the recommendations then in terms of managing the risk of cardiovascular disease? Again, from the recent guideline, monitor weight and BMI. Again, these look like common sense, and indeed they are. The frequency depending on what you find, of course. Consider ethnicity, for example, higher risk in South Asians. Address cardiovascular risk factors, obviously hypertension, smoking, etc. Monitor lipids and monitor blood pressure. And very briefly, PCOS and endometrial cancer. What we know is that there is an increased risk of endometrial cancer in women with polycystic ovary syndrome, but most of these data come from unadjusted data, and BMI clearly is a factor also in genesis of endometrial cancer. Again, it's probably the interaction of the two in women with polycystic ovary syndrome which is important. And indeed, in premenopausal women, a high proportion of those cases actually have polycystic ovary syndrome. Mechanisms, well, it may be chronic anovulation, unopposed estrogen stimulating the endometrium, insulin resistance and hyperinsulinemia may play a part, abnormal steroid environment, we don't really know. Management, well, you can essentially prevent it with progestogens, and in established endometrial cancer, then surgery, of course, is the treatment of choice. So just summarizing, ladies and gentlemen, these are the areas that I've tried to cover, some of them very briefly, depending on the symptoms, oligo or amenorrhea, hirsutism, obesity, quality of life issues. But I've focused on long-term health concerns, particularly the risk of type 2 diabetes, thinking about cardiovascular risk, because we can't assume that just because we haven't had an excess of heart disease yet amongst women with PCOS, it's not going to happen. So monitoring is important, but we're left really with this question: what and how often to monitor? So thank you for your attention. I'll just go and find that slide with the website details. Didn't realize there were quite so many slides. And I'm very happy to answer any questions. Can you go to the microphone, please? There's one right here, yes.
Stephanie Baldwick, London. Hello, thank you for your very useful talk. You very briefly touched on anti-androgens. And I wonder whether you would like to comment on the possible risk of meningiomas, bear in mind that they have a high percentage of progesterone receptors.
Yes, well, that's rather close to the bone at the moment, because you're talking really about cyproterone acetate and its progestogenic effect. Now, one of our patients who was given regular progestogens for management of her polycystic ovary syndrome actually did develop a meningioma, so that was a bit of a shock. So we need to recognize that is a possible complication. And indeed, when we're thinking about not just cyproterone acetate in management of hirsutism, but also progestogens in managing dysfunctional bleeding, that we don't really have enough in terms of the controlling the endometrium. We don't really have enough evidence that it does very much. We're doing it because we think it makes sense, but we have to balance against that the possible risk of long-term progestogens. It's a very good point. I think everyone's ready for their lunch, so enjoy.